So again, welcome everyone to our presentation today on understanding and preventing obstetric fistulas, presented by Wilfrida Otieno, and just a wonderful individual. I will first let her introduce herself, and then we will get started. My dear, you have the floor.
Thank you very much, Dr. Juan and Dionne. I'm so happy and excited to meet you here. My name is Wilfrida Otieno, a physiotherapist. I've worked in the Kenyatta National Hospital for the last 32 years, and I winded up as the chief physiotherapist in the Ministry of Health for the last 2 years. I'm here to take you through. I'm an orthopedic manual physical therapist and also a women's health pelvic floor physiotherapist. And I'm here to take you through understanding and preventing obstetric fistula, physiotherapy perspective. Thank you. So we are discussing understanding and preventing obstetric fistula, but mainly in the physiotherapy world, where I have been for the rest of my life. So I'll take you through definition of fistula, epidemiology of fistula, causes and types of fistula that we've been able to see and manage in the hospital I worked in, some of the surgical treatments of fistula, physiotherapy treatment of fistula, including the multidisciplinary team that we worked with in the management of those particular patients. Preventive measures of obstetric fistula, and follow-up care, which is also very important. And I will include some of the partners that are involved in the fistula management in Kenya. So what is fistula? It is an abnormal or surgically made passage between a hole or tube-like organs with the body surface. And in our purposes today, we are going to talk about that abnormality between the vaginal canal and the bladder, or the vaginal canal and the rectum, or sometimes the vaginal canal and both bladder and rectum. It is actually a hole that comes in between those particular organs. It is a devastating childbirth injury that leaves women most of the time leaking urine and stool, or sometimes leaking both of them. And sometimes actually this causes separation or divorce within the family. When the fistula forms, a hole comes in between those organs, and we are going to see those organs, how they look like. And that hole now creates a pathway for urine, for stool, and sometimes even for gas to pass through. So these are women who would leak these particular body fluids through a channel that was not naturally made for them. So here is a picture of the normal female anatomy, or how the female looks like in the pelvic floor. And the organs we are going to address particularly today are the bladder, the uterus, the cervix, and the vaginal canal, and then the rectum. If you are able to see my cursor, in front is the bladder, which is a store for our urine. And in it, there is a small tube that passes and exits through the pelvic floor, which is the urethra, where urine passes through. Then in the middle, there's the uterus, where the children are. In the middle, there's the uterus, where the womb for the baby in the female. And also the uterus has got a channel through the cervix and the vaginal canal. And if you see my cursor again, posteriorly or behind, there is the colon and the rectum and its own exit and pathway. So these organs are very close to each other, but they are pretty independent from each other, and each has got a different function altogether. One is meant to store the urine, another is meant to carry the baby, and another is meant to store the stool. So types of fistula by anatomic descriptions. When those organs are injured during childbirth, then a communication happens between them. And so in this picture, we are going to see exactly what happens. So we have 5 different types of fistula. Number 1 is vesicouterine fistula. This is a connection between the uterus and the bladder. And here is the uterus, and below it is the bladder. So if you can see through my cursor, the yellow line is the communication between these two. And this may mean that urine sometimes may actually overflow backwards into the uterus and get its pathway through the cervix and into the vaginal canal, instead of passing through the urethral tube and exit outside. That was our number 1 breakage of the tissues. Then number 2 is vesicovaginal fistula. This is a connection between the bladder and the vaginal canal. And so number 2 is right here. And there's a breakage between the bladder wall and the canal. And so urine, instead of being stored here, would be leaking backwards into the vaginal canal and exit outside through the vagina. Then we have number 3, which is the uretrovaginal fistula. And so again, that is, if you can see my cursor, that is on the tube in the pelvic floor of a female. The exit for urine, instead of now letting urine come through it, it is flowing back into the vaginal canal. Then we have rectovaginal fistula, and I think this is the most devastating one, because this is the rectum, which should contain stool, and instead of stool exiting through the anal canal, it is now exiting into the vaginal canal. And then we have uretrovaginal fistula, a connection between the ureters or the kidney tubes and the vaginal canal. So we have 5 different types of fistulas. And here we can see through the dotted lines that come from the ureters, and they have exited the bladder into the vaginal canal. So vesicovaginal fistula is the most common one, and it can involve the bladder, the ureters, and the urethra, everything around urine, and the small or large portion of the vaginal wall. Women who suffer this particular condition complain of constant leakage of urine throughout the day. They may use pads, they may use even diapers actually throughout, because they are never dry, they are always wet. And that means that the bladder never fills. Our bladder fills between 2 to 4 hours, and we get the urge to go to empty it. But in this case, these women may even lose that urge to go to empty their bladder, because it is always leaking out. Rectovaginal fistula, which I have just explained, is not as common as the vesicovaginal fistula. It affects about 10 cases of women, and women who have this condition may also suffer from VVF or from the vesicovaginal fistula. So here is the rectum, and from the rectum you can see a breakage of the wall, and so the poop that is inside here is actually leaking into the vaginal canal. So this is how devastating these conditions are to these women who suffer them. So types of fistula by cause, mainly it is obstetric in our case here, and this comes because of prolonged obstructed labor. And we also can call it gynecological, genital, or pelvic fistula. It is the most common type of fistula. This means that there are other types of fistula that happen within the body, but today we are particularly looking at the one that is caused by childbirth. It can also be caused by trauma due to rape, or sometimes because of female genital mutilation, and that is circumcision of the women, especially the 4th type, which is very severe. heals with scarring, and scar tissue actually will obstruct even the baby from passing through the normal birth channel. Then we have accidental injuries during different surgical procedures that may happen in theater, especially when people are being done cesarean section or hysterectomy is the removal, total removal of the uterus, or other pelvic surgeries. Occasionally that can happen as an accident in theater, and that may also cause a fistula. Epidemiology of fistula. According to the Worldwide Fistula Fund, 2 million women and girls suffer from fistula, and each year 50,000 to 100,000 women are affected worldwide, but about only 20,000 get corrective surgeries. So you can imagine the number of women out there who do not access care. 20,000 girls age 18 give birth every day in the developing countries, and Kenya is one of them and is not accepted from this. Actually, these girls sometimes are not even just 18. My experience from Kenyatta National Hospital, we got to get these girls even at the age of 13, 14, 16. Some of them even had fistula at that particular age. And then about teenage pregnancies, we saw it during the COVID-19 lockdown in 2020. About 152,000 Kenyan teenage girls were pregnant. And that shows you how many teenage pregnancies are around these countries. 3 to 5 cases in 1,000 women pregnancies in developing countries get a fistula. And a woman may suffer from fistula for 1 to 9 years, but our experience have shown us that they actually suffer for longer period, because we saw women who came to our places who had suffered from fistula for 10 to even 30 years. For women who have suffered fistula, we are told that 70% of them even do not have living children after that. And most of the time, fistula can be cured, and it can be cured through surgery and through physiotherapy and through proper multidisciplinary management. The global fistula map shows that in the developed countries, the fistula has been actually eradicated. And that's why my 2 lecturers have requested us to present, because it happens more in our country. The condition remains prevalent in sub-Saharan African and Asian countries, and Kenya is not exempted. Obstetric fistula actually affect the woman physically, psychologically, and even socially. With a continuous leakage of urine, there's a bad odor. And most of the time, these women go through isolation, stigmatization, and even rejection by their very closest partners, their spouses. So these women eventually, when that happens, they lose self-esteem, they lose the confidence to even involve themselves in economically gainful activities. So they have activity restriction, activity limitation, and participation restriction. In Kenya, it is estimated that annually there are 3,000 new fistula cases, but only 7.5% get treatment. So we have a long way to go in this process. And that's why I have a passion to talk about fistula, because I believe we are supposed to be part of the team that will help to eradicate fistula in this country. Causes of fistula. It develops during labor when the infant's head descends into the pelvis but cannot pass through, creating a sustained pressure, and that sustained pressure actually derives the tissues around it from oxygen and from blood supply, and therefore the tissues there die or they go through necrosis. And this type of death of tissues creates the hole that I was talking of earlier on. And therefore the bladder that was so independent from the vaginal canal will now communicate, because there is a hole between them. And even the rectum will now have a hole. depending on how the baby is lying in utero and how the baby is actually engaging during childbirth. If the baby is more anterior or more in the front, then the bladder will be more affected. And if the baby's head is lying more posteriorly or more backwards, then the rectum will be more affected. And if the baby is in the middle and stuck there, then it means this mom will suffer from both urine leakage and stool leakage. So that's what happens when these moms get their fistula. And we call it dystocia in the medical term, or prolonged obstructed labor. Sometimes this occurs because of the passenger problems, and the passenger is the baby. The baby may be bigger than the pelvis of the mother. Or sometimes this happens because of uterine power is not enough to expel the baby out. Or sometimes the mother's condition has changed from good to worse, and therefore she's not in a position to be able to deliver a baby. Most of the time, these moms who go through obstructed labor will be in labor for a week, 3 to 8 days. And I think labor is one of those things. I hope you are able to hear me. Joanne, are you still hearing me?
Yes, I can hear you well.
Hello? Oh, great.
We can hear you well.
Great, thank you. I was just checking that everybody is on board. So I think labor is one of the greatest stress tests that anyone can go through. And you can imagine a woman being in labor for 3 to 8 days is very strenuous and very devastating. So I've talked about prolonged labor in childbirth, and then I also talked about accidental surgeries that may cause a puncture in one of the organs. And then there are also diseases that can cause a fistula, like cancer of the cervix or sexually transmitted diseases that are not treated can bring infections. And sometimes it can also be caused by miscellaneous conditions like congenital deformities, whereby children are born with their bodies or their body parts not completely developed, and or traumas and foreign bodies that may have been left in the patient's body through surgery or something like that. So risk factors of obstetric fistula are included in the duration of labor that is greater than 24 hours. I've said some moms go through labor for even 3 to 8 days, then seeking delivery services after 6 hours of labor onset. This happens a lot in Kenya, where you find women may not be going for antenatal clinics, and when the labor starts, they are still at home and they have not started even the process of trying to go to the hospital on time. Then taking more than 2 hours to reach a health facility. So some also are very far from the hospital places, so they are trying to look for transport that can take them to the hospital there in that status of emergency. And lack of access to antenatal services and emergency obstetric services. I've been a midwife one time when I went home and I found a niece of mine was already in the process of delivering and she had not even prepared herself to go to the hospital. So I had to be the midwife and help her get this baby out because the baby was already engaged and we could not reach the hospital in that status. So those are some of the things that find us in this country. Then lack of skilled birth attendants, midwives in more remote or rural areas is still existing, but I believe the Ministry of Health is working on it, and that is why they are really trying their best to implement universal health care so that there is access to health for all mothers who are expectant and the services are within reach. So those are some of the situations that we are in. I think I've explained what obstructed labor is, and I can skip that slide. This is another cause of obstructed labor, when the baby's head is bigger than the mother's pelvis, and so the baby cannot actually descend and exit the uterus, so it gets stuck. It is a major indication of cesarean section in our setup, where moms are able to access the hospital care. So risk factors for prolonged obstetric labor are younger maternal age, which predisposes them to obstruction because of the narrow pelvic architecture, marriage at an early age before the pelvic is completely developed, and this happens a lot also among some of our communities in Kenya. And then there is malnutrition that can also cause the pelvis of a teenage girl not to develop to maturity to be able to carry a baby in some of parts of Kenya as well. There's perineal tears, especially during childbirth. Childbirth is actually a very traumatic process, and sometimes a mother can go through perineal tear as severe as 3rd to 4th degree. When this happens, it means that the sphincters, the anal sphincters, or the muscles that line the rectum and the bladder get torn in the process, and therefore that would cause that type of hole that I was talking about, and the mother will leak. So women of this type of injuries during childbirth, sometimes they may complain of fecal incontinence or urine incontinence immediately after birth, but sometimes there may be a delay. It depends on the type of injury they had and the severity of that injury. Surgery is the best way to repair this, and when surgery is done, then physiotherapy should follow immediately, because the muscles don't get good strength enough. The surgery repairs where the hole is or where the tear was, but exercise gives strength to these muscles. Therefore, the need for all of us to work together. And signs and symptoms of obstetric fistula. Number 1 is leakage of urine through the vaginal canal. Leakage of urine not in the right place. Number 2 is difficulty passing urine. Sometimes there's urine retention. The other one is leaking of poop through the vaginal canal, like I'd explained earlier, because a hole has been formed between these organs. Then there is skin irritation. These fluids, urine and stool, have got a higher pH. So when they come into the vagina, they would cause irritation of the muscles around there, and that would cause even sometimes bleeding through the vagina or through the rectum, and would also cause pain with intercourse. That type of fluid being retained in the wrong organ or in the wrong pocket can also cause kidney infection, and it comes with foul smell and foul discharge, and therefore that causes recurrent urinary tract infections. So evaluation of the fistula. Number 1 key is the patient's history. In the history, we get to be, the health worker is able, and especially the physiotherapist, the nurse, and the doctor, they would be able to have a differential diagnosis right away. Because when it is a fistula, there's continuous leakage, and the mom always has a pad or always has a diaper. But when it is other leakages like stress incontinence or urge incontinence, then that is urine that is passing through the normal channel, but the patient is just not able to control it. So there's a big difference, and the treatment is in the history that the patient gives you. Clinical presentation of the mom, vaginal examination is a must, and there are several diagnostic tests that can be done to just confirm the type of fistula and where the fistula is. There's dye test and water and air, flat tear is inserted into the vaginal canal just to check what's happening in the process. Then there is also imaging, which is IVP or urography, cystography, sometimes CT scan may be required, or MRI. Important notes for the mother, who have suffered prolonged obstructed labor, it is actually important to ask these moms how they delivered, whether they delivered a live baby or whether they had a stillbirth. It is also important to recognize their emotional pain and their emotional loss, especially when the baby died. We've seen that most of the time, these babies are never born alive. So that's why they need to be very empathetic as you take this type of history from these moms. If the child survived at all, then it is also important for the health worker talking to this mom to know the status of the child, whether the child is fine or the child also suffered developmental delay because of brain damage during childbirth, a difficult childbirth like that one. And therefore, there may be need for you to refer the child also to the relevant health worker who will take care of both mom and child. And it is important to take care of both mother and child in such a scenario. So medical consequences of untreated fistula are vulvar excoriation or raw irritated lesions and dermatitis around the vulvar area and around the perineum, frequent ulcerations and infections like I've explained in the earlier slides, kidney diseases, and sometimes death, because kidney comes with major complications when there is other injuries to the body. There may be dehydration because these moms are thinking that if they take in less fluid, then they will not leak. So they try to limit a lot of fluids as much as possible. And then occasionally these moms also have not just the perineal tear or the perineal damage, but they also have damage to the nerves and the muscles that are supplying the lower limbs. And therefore they may easily get inability to walk or sometimes develop contractures if they are not taken care of. So the role of multidisciplinary team is to restore the pelvic floor function and implement pelvic floor muscle exercises and evaluate the mother accordingly or holistically, so that if there are other issues or like musculoskeletal issues, then they are all addressed. And the ultimate goal of the fistula surgery is also to restore normal function of the lower urinary tract and any other pelvic structures that may have been affected by that injury. These moms also need the psychological support and self-management, and therefore there is need for the clinical psychologists to also be on board. And because sometimes the fistulas recur depending on the type of care that this mom has gotten or the type of fistula that this mom presented with, it is very important to encourage them on a follow-up care, so that should there be a recurrence, then there is adequate treatment on time. So surgical treatment, most of the time it is 80 to 90% cure for these moms who suffer fistula. Although 90% are left untreated, treatment capacity is only around 15,000 per year, and a big number are left out who require that type of surgery. And that happens because of the shortage of the surgical doctors or surgeons, the shortage of the hospitals that can take care of this across the 47 counties of Kenya. And the numbers keep increasing every other time. In Kenya, the surgery may cost about 65,000 shillings in the National Hospital, and this is not within reach of most of these patients. And therefore, on and off, we have camps in different counties at the moment that can actually treat these mothers free of charge through the support of the Worldwide Fistula Fund, the AMREF Flying Doctors, and even Freedom from Fistula. And Kenyatta National Hospital has been in the front line of doing this with these particular partners. So postoperatively, I wanted to talk about the nursing care because I'd mentioned earlier on about the multidisciplinary team, and all of us work as a team for the benefit of this particular patient. So the nurses will be found in theater and they are also in the ward. So when the patient comes back from the ward, from theater, the nurse needs to settle the patient well in bed and confirm that the catheter is draining well. She also needs to maintain intravenous fluids at least 3 liters in 24 hours. She may need to give analgesics and antibiotics as prescribed by the doctor. And the patient should not ambulate until the packs are removed. And vaginal packs are put in to help with the fluid drainage and also to help with giving compression around the scar tissue so that it can heal well. So this pack may stay for 24 or 48 hours, depending on the surgeon or on the type of surgery that was done. And of course, when the pack is removed, the mothers are encouraged to keep vulvar hygiene. They're supposed to wash the vulva 3 times a day with clean water. Again, when they come in with the catheter is supposed to stay in there for 1 to 2 weeks. And we start training them or training the bladder to be able to get into distension, to be able to carry back the fluid. So it is important that while they still have the catheter, it can be clamped for 2 hours just to help start retraining the brain and the storage of urine. Then the mothers are advised to have bed rest at least for 2 weeks and avoid strenuous work. Exercises are prescribed accordingly and appropriately by the physiotherapist. A balanced diet is also advised accordingly and appropriately by the nutritionist. And they are supposed to take a lot of water, 50 mils of water times their body weight. This is just to help clean their system. They are also supposed to be advised to abstain from intercourse for 3 to 6 months, depending on the type of surgery that they had. If it was a vesicovaginal fistula, then they're supposed to abstain from intercourse for 6 months. And if it was RVF, then they're supposed to abstain for 3 months. So this is something that patient education must begin early and must be done by all the health workers within that area so that the patient is able to understand. And you only don't talk to the patient alone, you also involve family and more so the spouse so that they can follow this particular rule. Because I've seen patients who actually came back with broken repairs because they had intercourse before the pelvic floor got to heal. So this is very key. Family planning education is key because once a mother has suffered a fistula in a pregnancy and delivery, then subsequent deliveries should be done through the cesarean section. And this can only be done by the health worker who is having contact with that mother. And indeed, these mothers, because I'd said earlier how the fistula affects them physically, emotionally, and mentally. Therefore, they need to be able to involve, including the social worker, so that they can be reintegrated back into the society. A follow-up of visit after 6 weeks after surgery is important back to the surgeon, but for the physiotherapist is equally important so that now we look at the scar, how it looks like post-surgery, because our body is healed by scar tissue, and therefore the need of the physiotherapist to start vigorous physiotherapy regime after the surgery. So patient education is key, especially in physiotherapy management. Activity modification, one of the activity modification was abstinence from sex, and then doing light duty or light chores or involving the family to help this mom with the house chores. Physiotherapy process is inclusive of all that we do and we may not be able to talk about it in this session tonight. In postoperative physiotherapy, we address early mobilization to reduce cardiopulmonary issues or respiratory issues, and therefore Within the 6 hours postoperative, we encourage patients to do breathing exercises and foot and ankle exercises, and we wait for the pack to be removed for us to be able to ambulate them out of bed. Yes, yes, yes. I've seen your hand, Doc.
We'll answer
Am I-
questions once the presentation is over. We'll have a good bit of time for Q&A. So hold on to your questions and we'll answer those at the end.
Thank you very much. So as physiotherapists, we also advise them or to take a lot of fiber, and we will be helped by the nutritionist who is usually on board so that we prevent constipation. And should there be constipation, then there's something we can do called abdominal massage that will help with stimulating the peristalsis and ease of bowel movements. Then the pelvic floor muscle is the domain of the physiotherapist and is the one who can do it in the best way possible. So as we were doing clamping with the catheter, when the catheter is now removed, then we can also start prompted interval voiding of 2 hourly, and also to retrain the bladder to be able to store the urine until the patient has the urge to void. So that is very important for us to do. All this program here can only be taught in a class of the pelvic floor physical therapists. But it is important to let the patient go home with a bladder diary. In the bladder diary, if the patient is not able to write, then you can give a patient an envelope and tell her that every time she goes to the toilet, she can put in a bin or a maze, so that at the end of the day, she knows how many times she has visited the toilet. And when she comes back to you, you are able to evaluate how well she's progressing on with her bladder training. So all this is pelvic floor assessment by the physiotherapist. We should assess whether the breathing patterns are coordinated with the pelvic floor. We should assess the abdominal muscles. If there should have been a rectus diastasis, then we know how to manage it and manage it. We should access the pelvic floor for scar tissue and be able to make it better. And also, if we have to do an internal exam at all, we only do an internal exam when it is appropriate and by a qualified physiotherapist who is able to carry out that procedure. And why do we do internal exam? Just to confirm how the muscle tone looks like, whether there's tenderness, whether there is pain, whether there is weakness, so that we are able to, this guides us in the program regime that we need to give to the patient. So other musculoskeletal rehab, we say treat what you find. After you've examined your patient thoroughly, you know exactly what you want to know to address in the patient, whether it is strengthening exercises or conditioning exercises or postural correction exercises. So there's a lot that the physiotherapist come with on board to help this patient so that the patient can go back to do the activities of daily living as appropriate as possible. Sometimes there may be obstetric fistula repair failure even after surgery, and this happens most of the time when the urethral damage was so severe, or the fistula size was too big, or the duration of labor was just too much that so many tissues were destroyed in the process, and also the type of fistula. And some moms come with previous histories of repairs. So that's why they are encouraged, instead of having another repair, they should now deliver through the cesarean section. And trends and further management, we encourage mothers to come to us for at least 3 to 6 months, or for 6 months to 12 months. That means within a whole year, and be followed by the whole MDT, so that the mother gets quality of life. So post-op visits allow recognition of persistent urinary or other musculoskeletal issues or dysfunctions that may need to be addressed in a new way. So prevention is key, and that's why I'm trying to give this lecture here today. And thank you very much, Joanne and Dionne. So just like the developed countries have managed to eradicate fistula, so also Kenya should be on the line to be able to eradicate this devastating condition. And what should we do? We should improve access to emergency obstetric care. We should improve access to antenatal care, education, and empowering. We should train more skilled birth attendants. And I'm happy this is already in the process within Kenya. We should improve nutrition and limit growth deficiency, especially in the developing pelvic of young girls. We should avoid early marriages and teenage pregnancy, and also do family planning. So in summary, pre-op and post-op management of fistula patients is key, and it's very important that we do this once the patients are admitted in the ward. Other musculoskeletal dysfunctions that are present should also be addressed, and the role of the physiotherapist should not be overlooked. That's why I'm requesting, if there are any doctors listening in here today with us, let us work together for better outcome for these mothers. Some of the partners of fistula management in Kenya are the Flying Doctors Society of Africa, Freedom from Fistula, the 3Fs, Fistula Foundation Treatment Network, Safaricom Foundation, M-Pesa Foundation, and Citizen Foundation. And some of the hospitals that carry out fistula care in Kenya are Bomu Hospital in Mombasa, Cherengani Nursing Home in Kitale, Darajambili Vision Volunteers in Kisii, Gyno Care Women's Fistula Hospital in Eldoret, Jamaa Home and Mission Hospital in Nairobi, and Kisii Gyno Care Fistula, and all the other county referral hospitals at the moment, I think, are trying to carry projects on or to do fistula camps wherever they are. And I'm requesting the physios who are out there to jump on that boat and help the patients better. Kenyatta National Hospital has also been doing the fistulas, and you can Google their website and reach out to Clinic 66 for advice. Thank you very much, and that comes to the end of my presentation.
Thank you so much for that. There was so much information in there, and it was just, I don't even think 40 minutes, 45 minutes can do a topic of this magnitude justice. But I am eternally grateful for you and for all that you brought to the table with this topic, because it is something that is impacting so many lives globally. And we definitely need to find ways to address this. And like they always say, prevention is better than cure. And I think if we can at least educate, communities and birth workers and physicians, right? And let them know what resources exist, how we as therapists can be helpful, and how all of these interventions can drastically impact fistulas in a very positive way. I think that we can start to move the needle forward for persons within our communities to really get the help and care that they need. Dr. Middlebrooks?
Mine is more so just a question that way. Hopefully, Ms. Wilfrida, you can address this, but could you let us know what percentage of births are happening out in the community and what percentage of births are happening in the hospital, and how that compares with what you all are noticing with these fistulas that are occurring?
Thank you very much, Dr. Dionne. I don't have the actual figures, but I know that In 2012, when we did the camp in the teaching and referral hospital, we had more than 1,000 women who came to the camp for us to even to filter them. But as time has gone by, now even if there is a camp, you find that the women coming are about 500 or 300 to 500. So the number has reduced, meaning that something is happening. More women are coming to the hospital and more women are delivering in the hospital. I know that the government at some point, especially in the previous years, they had what we call a Linda Mama project. And that meant that all women could access antenatal care and deliver in the hospital without having to pay some money. And I think that must have reduced the number of women who are delivering at home drastically, and the percentage has gone up. I'm sorry, I didn't check on that percentage, but the ones who are delivering in the hospital have actually increased in number because of that. Thank you.
Thank you, and thank you for a wonderful presentation. This was amazing. And like Dr. Martin said earlier, we don't really see a lot of these in the U.S., and if we do, it's normally individuals who've already immigrated over here, and they've been dealing with these issues for a number of years. So thank you so much for the refreshing perspective on this.
Thank you.
At this time, I want to open the floor for any persons who may have questions. Feel free to raise your hands or feel free to type your question into the chat so we can read them and have Ms. Wilfrida answer those questions.
Well, while individuals are thinking of questions, I will ask this one as well. I know, Wilfrida, that you mentioned that with the number of hospital births increasing, that appeared to help decrease the occurrence of fistulas. What are some initiatives that you would recommend to help with the community and home births? Because let's be honest, not everyone's going to be able to make it to a hospital, and even some may not desire to go to a hospital. So what are some things that you think could be implemented that better help serve these communities?
At the moment, I think in 2 years down the line, the government employed community health workers, a big number across the country. And so I believe some of them among the community health workers are also trained in a way that they can be able to carry out childbirth if it is not complicated. But there are also traditional birth attendants who are found within the villages. So among those are the ones that have been encouraged to be community health workers also. And so if moms cannot be able to reach the hospital, I believe those people are in a position to help. Again, the Kenya government or the Ministry of Health is actually trying to implement universal health coverage so that within a square meter of 5 kilometers, there must be an health center where people can get health services from qualified personnel. So I believe those being put in place may be able to help us eradicate fistula at some level. Thank you.
Wonderful. Thank you for that information.
Dr. Remy asked, in view of the number of women, how many physiotherapists are available to work with them? So given the number of cases that you have, given the extent of the prevalence rather of obstetric fistulas, how many physios are available? What do those numbers look like?
Okay. In Kenya, I think we have about 2,500 physiotherapists, but among all those, a big number work in the national teaching and referral hospitals, like Kenyatta National Hospital has about 70 of them, and the bigger numbers are working within the government hospitals. Then the ones who are qualified in pelvic health are only about 40 in the whole country. Majority of them are within Nairobi County, meaning that the other 47 counties have not had the pelvic health specialists in terms of physiotherapy. It's only now that I think in the first cohort of AMREF that we've seen a few counties being covered. It's only now that we are seeing one has come from Mombasa, two have come from Vihiga, and one has come from Nandi, and another has come from Kisii. Otherwise, the rest of the other 40, for about 40 counties of Kenya, do not have a qualified physiotherapist to handle these cases.
Someone else asked, what types of exercises do you recommend for fistula cases?
Well, the exercises are tailored according to each patient's need. So before you recommend any exercise, you will have to take the history of the patient, examine the patient from musculoskeletal to the pelvic floor, and then from there you are able to design your exercise regime. But what we do preoperative exercise regime, especially for the pelvic floor, and breathing. Like I'd said earlier on, breathing is coordinated very well with the pelvic floor. So you check on how this patient is breathing and actually correct the breathing if there was any issue there. And then you do pelvic floor exercises. So the pelvic floor exercises that we do, you have to help the woman isolate where those pelvic floor muscles are so that she doesn't recruit the other accessory muscles that help the pelvic floor. And therefore, the exercises are actually tailored to individual patient according to the need. It's like a prescription, a drug prescription, but now these are exercises. Thank you.
Mhm. And I would say one of the questions that I had to ask, you mentioned a lot with regards to the social implications, the psychosocial implications with a lot of women. You mentioned divorce rates can be high as a result of this, and so on and so forth. What is being implemented in the way of collaborative care, such that individuals are not only getting surgical care, they're not only getting physical therapy, but they're also getting social resources, mental health resources, family resources, in a way that can help these individuals, because we know it's not just the symptoms, it's not just the incontinence, it's not just whether urine or feces, but there's so much more that can happen, including the financial toll that this can take. So what is being done with regards to that in the way of multidisciplinary care to help individuals?
Thank you very much. In the hospital I worked in, before we had the surgeries or the camp, everybody would be on board to have a discussion and a plan on the way forward. And everybody here meant the multidisciplinary team, the occupational therapists, the physio, the surgeons, the nurses, the midwives, the clinical psychologists, including the social worker, so that this social worker will be able to follow this patient up to home and just take care that the patient can be integrated back home. Again, the partners who have been partnering with KNH, some of them actually give life skills to these women. The Freedom from Fistula or the World Fistula Fund, I know they have some life skills that these women are trained to do something that they can be able to be reintegrated back into society. And then the clinical psychologist also helps these women to be able to adjust to themselves and just do self-care that can enable them to regain back their self-esteem and their mental well-being. So it's not only the physical part that we are trying to manage, but we want to manage this woman holistically. and back into settling her into her own home. Again, the family, like I'd said earlier, the whole family should be involved so that everyone else can come on board to help this particular patient or client be integrated back to the society.
Mhm. Veronica asked, with the cost implication, is post-surgical rehab covered?
Sorry, I didn't get that one.
Is post-surgical rehab covered? Given the high cost of surgery, is post-surgical rehab something that is covered with the, for persons who are undergoing surgery?
Great. So the package that we used to have then was that the woman would go for surgery and have at least 5 sessions of physiotherapy that were covered. Yeah. And so we will do one pre-op management and then leave the other 4 for post-surgery. And even the ones who suffered stress and urge incontinence would still get a 5 sessions package free of charge. I don't know how they are doing it in the counties, but that is something that needs to be discussed. And like I was saying, we need to see these women even for 1 year down the line after surgery. The physios who are working with these women actually need to be their advocate and help the partners who are trying to pay their hospital bills know that there is also care after the surgery that needs to be taken care of. So it is an area we need to work on further. And that's, I think, one reason why we are also having this webinar, so that we can create that awareness that we need to be the advocates and help them where they need help.
Someone else asked, are men well educated about fistula? What is their reception about it? Are they supportive to spouses? So can you give a little bit more discussion surrounding what is typical of spouses and fistula and the occurrence of fistula?
In my experience, it was a sad story about spouses and fistula. In my experience, actually, it brought tears to our eyes because the women would say either they were long separated with their husbands because of the odor that came from their bodies because of the leakage, or they were long divorced because of that particular condition, or the ones who were done surgery, and if we didn't bring the spouse on board on time, they come back for a repair, another repair of a broken fistula because the man did not know that he needed to abstain. So another area where we still need to do a lot more so that when we are talking about fistula, we talk about the whole community and more so about the immediate family. Thank you.
Yeah, it's really sad to hear stories like that. Especially when partners just don't get it. It's really sad. Someone else asked, with the prevalence of female genital mutilation among various tribes in Kenya, that is one of the risk factors of fistulas. How do we incorporate cultural change to reduce fistula in these communities, in these community matters, educations, fidelity, reach, and feasibility? So what's being done with regards to FGM to help reduce the rate of fistulas?
What I know about FGM today is that many people, even the ones who've been done FGM, are actually coming up to be advocates against FGM. And that is going the right way or the right direction. And again, the government of Kenya actually made FGM to be an outlawed, an illegal procedure to be done to anybody within the Kenyan community. But I know this still happens, and what these communities have done is that they have medicalized FGM. Instead of doing it the traditional way, the way they used to do it before, they now sometimes ask or get some medical health workers to do it. And I believe that is still illegal, and therefore FGM should actually be eradicated completely. But before we go with force to say it must be eradicated and it was so engraved into culture, we actually must find a way even of how we can replace. We can give this community, we can discuss it. It should be a dialogue between these communities and among these communities on the procedures that we can use to initiate our children into adulthood so that we leave very devastating procedures like FGM.
Mhm.
Yeah, all those are gray areas that as a country we have not well worked on, and we need to work more aggressively on them so that we can eradicate fistula in the best way possible in all different angles.
Absolutely. And we will be having Ms. Wilfrida come back in April for our April session to discuss female genital mutilation. So I look out for emails with regards to that, to register for that, because we will have her back to discuss female genital mutilation, which again is a very big topic throughout the continent, and is still happening in many tribes and in many areas. So someone said during the previous medical camps in our health facility, post-op, some of the patients developed urinary retention after 2 weeks when the catheter was removed. What is the best physiotherapy management for this?
Okay. When immediately the patient, sorry for that. Immediately the patient comes from theater, both the physio and the nurse should be very keen about how that catheter is placed and how it is draining, and whether it is draining or not, and how much is draining. Again, that catheter also depends on how much fluid this patient is taking. So all those are our key areas that we have to keep an eye on. And therefore, if there is retention, then there's not much we can do when there is retention. In there, we call the doctor or the surgeon to help handle retention. Ours is actually when there is leakage. We are better placed to handle leakage than retention. So if there is retention, please refer the patient back to the hospital if the patient had gone home, and let the patient be assessed again and just check the position of the catheter, if it is in the right place or not, and why it is not draining. Yeah, so I think that's what needs to be done. So I talked about the catheter earlier, and I said we can do 2-hourly clamping of the catheter and just see how it is draining, and then we release. And again, after another 2 hours, we clamp and see, just to retrain the bladder, for the bladder to know again, because I'd said how long these women take to come to the hospital for care. So you can imagine that bladder, how long it has been leaking and has not been storing urine. So there is need to retrain it, and the retraining of the bladder is step by step. It doesn't go full time, 4 hours clamping. Some of the patients, you may even start clamping for 30 minutes or for an hour, and then you progress the number of minutes you are giving this particular patient as time goes by and as the patient responds. So we all keep an eye. If it is not your case, please refer to the relevant health worker. Thank you.
And I just want
I would
to,
also say to be mindful, sorry, I was also going to say be mindful of the output, the urinary output. So not only amount, but we're also looking at color. Is there blood in the urine? Is the person complaining of pain in that suprapubic region? Because these could all be signs of potential infection, which is not uncommon with catheter placements. UTIs can happen, but also just bear in mind that the catheter is being inserted into the urethra, which for some people can be irritating, cause a little bit of an inflammatory response, so that even when the catheter is removed, there may be some swelling that occurs afterwards, and that in and of itself is also prohibiting urine flow. So definitely go back to the provider, but as pelvic health physios, know that you have a place here as well to get in there with some manual therapy techniques and work on helping to alleviate some of that pressure in the area and addressing any of the urethral limitations that might be happening, including some scar tissue and adhesions.
Thank you, Juan, for that further explanation. That was very informative.
I was going to say the exact same thing, so I won't repeat that portion. But the other piece I was going to say is that when you're sending people home after the catheter's been removed, sometimes some people, depending on the setting, they may even go home with the catheter. But once the catheter is removed, you want to make sure you emphasize the importance of them tracking their urine output. Because 2 weeks, the question said 2 weeks. 2 weeks is a very long time to go by for someone to now be showing up for urine retention. That's something that if we're educating them better, we can usually catch no more than 24 hours. And depending on how much urine there is being pretty much kept in the bladder, not able to escape, maybe even sooner, especially if the person is well hydrated. So your patients still need to be drinking plenty of water because the urine color is important. And if you're noticing the urine is a dark color and it has a strong odor to it, they're dehydrated. And the dehydration itself is going to further irritate the bladder. All of those structures need to heal. So you should have them track their urine output regardless of how they left the hospital for the first, honestly, not going to say 2-3 weeks, I'm going to say first few months. So that way you have an idea, because it's going to take time for those structures to heal. It's going to take time for the body to begin to go back to normal as well.
Mm-hmm.
Thank you very much, Dionne, for that input.
We have, given that the majority of us are generalists, how can we do screening, education, and refer appropriately? How does referral look like among physios for specialist care? I think that's a very wonderful question there.
How referrals look among physios for
specialist care. So for those physios who are probably mostly just musculoskeletal physios, orthopedic physios, they are not necessarily pelvic floor physical therapists, but they might be encountering individuals with a history of fistulas, or they might be the ones that might be seeing them for the first time. That might be the first medical interaction these individuals have had. So how do they screen, educate, and refer appropriately?
Great. That's a great question. I want to say pelvic health is a very new specialty in Kenya at the moment. And even among ourselves, I don't think we have all known that there are pelvic health specialists existing within the country. And so the referral has not started flowing in as much as possible or as is required. But the ones who already know are beginning to give a call and even to give a note and even to refer. So among ourselves, the referrals have begun. The other challenge is among the physicians. I think the physicians are not referring their patients enough, because like all moms who've delivered, they should come back to physiotherapy 6 weeks postnatally for the postpartum care. Because like I'd said earlier, delivery injures the pelvic floor muscle. And so the need for those referrals. So whether they have fistula or not, they all need a pelvic health specialist. And this type of referrals have not yet begun in our country, I would say. They are beginning, but in very small ways. And so we hope that as physios begin to realize the existence of pelvic floor physiotherapists, themselves who are in the rural areas will take the advantage and actually come for the course, so that out of the 47 counties, we can have the pelvic health specialist. Because even if you wanted to refer, sometimes the cost for the patient may be too expensive. Like I'd said earlier, most of the pelvic health physios are within Nairobi. So if a patient is all the way in Kisumu or in Siaya, referring that patient to a pelvic health physio in Nairobi may be very costly for the patient. So I'll just take that question and come back to you physios who are listening in here tonight, that please encourage your colleagues to come to AMREF for this course when we still have the experts who are teaching us, like the two doctors who are in the webinar tonight, Juan and Dionne. so that you get it from the horse's mouth, from the specialist's mouth, as you go back with the knowledge and skills back to your county. Because people suffer from pelvic issues, and most of the time, because pelvic is such a private area, they never talk about it. That is one reason why women would suffer for 20, 30 years without coming to seek for help. Yet these patients are existing from pediatrics to women to men to geriatrics, and so they are all over the 47 counties. So please come and get this expertise so that we can help people across the board. I hope I've been able to answer that question. Thank you.
Someone said during prenatal classes, awareness should be created to the expectant mothers on some of the complications that are likely to occur so that they can know what to do in case they experience it. So that was more of a comment versus a question. Someone else asked, what are some common complications associated with fistula that physiotherapists should be keen on when attending to those affected? So what are some of the common complications that you all see with the fistulas? Can you still hear us? All right, we'll give her a moment. Miss Wilfrida, if you're still there, just let us know. I don't know if it's a connection issue. With regards to that question, and I'll let Dr. Dionne answer this too. One of the things that, as with any surgical procedure that we're looking for, things like infection, would probably be one of the primary things that would come to mind if we're dealing with a fistula. So we're looking at things like abnormal swelling post-surgically. We're looking for discharges, foul odors, increased discharge, things of that sort. Abnormal increase of pain. So with any surgical procedure, they're going to have some discomfort. However, if there is an abnormal increase in pain, pain continues to increase versus decreasing, especially with the use of any type of pain medication, then that can also be a red flag. Again, things like redness to the area, to the surgical site. Those are things that immediately, when we're speaking to patients, we're educating them about things to be mindful of, things to watch out for on a daily basis. Those would probably be some of the primary things that they would that we would need them to be keenly aware of. Dr. Middlebrooks?
I just want to add more so on the bladder training side of things, because yes, infection is probably going to be the number one thing that we need to speak of, which Dr. Martin just mentioned. But on the bladder training side, you may have women who experience incontinence for a while after this, especially if it is, and not just with the bladder, but also with the bowel, especially if it is, especially if it was impacting, more so speaks to the bladder first, impacting the vaginal region with their urethra. They may not have good control of the bladder simply because the bladder has been able to empty at its own will. So the bladder has not necessarily had to stretch as much, meaning that as the bladder's filling, it can easily just leak through the fistula that's present between the urethra and the vaginal canal and just continue to come out. So some women may notice some incontinence. Some of it may be spastic based simply because the bladder's not used to it. Other times they may not even realize it once the fistula is repaired because they don't have the control of the voluntary control of the external sphincters. And the same thing can happen involving the rectum. One big thing to be mindful of with any surgery, especially with surgeries involving the pelvic floor, is constipation. You want to speak to people about constipation management because constipation can actually make this worse. Constipation can also prolong healing for various reasons. One simple reason is that now you can have ischemic changes because now you have the pressure of a rectum that is full, pressing on the area, so the area that should be healing is not able to heal as well. Also, constipation can increase your risk of infection because now if the stool's not moving through, it's able to just sit. With the constipation, we also can have changes in the intra-abdominal pressure. Because people want to strain to push it out when we should not be straining. But if they're constipated, that's what they're going to do. So you really want to emphasize the importance of proper nutrition, proper hydration, getting enough fiber, and utilizing books or a squatty potty, whatever they may have, so that way they can get into a better toileting position. If they're sitting on the toilet, if they're squatting, teaching them how to squat as well. So those are the things I would really mention is the incontinence can still occur, and it does not mean that it will not get better. It just may take time and pelvic physio. And then also constipation, we've got to manage that early on.
Mhm.
Thank you very
Absolutely.
much. I think I lost you at some point, but I just want to add that other complications may be a patient throwing embolus because the physio did not start on time in bed. Because as much as we advocate bed rest, we must do foot and ankle exercises, breathing exercises on time, so that we prevent respiratory and we prevent cardiorespiratory complications. Other complication may be because of infection that you've both talked about. There may be broken sutures because of infection, not necessarily because of lack of abstinence. And so therefore there is need for antibiotics immediately post-op so that that is prevented.
Mhm. So we'll take a couple more questions. Someone asked about clamping. They mentioned that they've seen situations where the catheter is removed without clamping, and patients end up with leakage. Is clamping the main routine of catheter removal? And I would say here it is. Anytime a catheter is going to be removed, a catheter has been placed, whether it's for something as simple as someone had an epidural or someone is having a cesarean birth or for any other procedure, once they are going to remove it, they clamp it first and then they remove the catheter from the urethra. And that's pretty commonplace. So that's something that we usually will see happen. Wilfrida, is that pretty consistent there?
Yeah, that is exactly how to remove a catheter. And I think that's what is most practiced, and especially if the catheter was put in situ because of pelvic surgery.
Mm-hmm.
Yeah.
Absolutely. Someone commented that thank you for highlighting the role of PTs in this area as it's mostly discussed as just a surgical intervention. We have such a huge role to play. Our profession is so very much needed, and it's conversations like these, especially when we can get our medical colleagues, physicians and nurses involved, that they can hear the perspective and they can see that one, involving the physios helps to improve surgical outcomes. Because if we can collaborate together, and when you're discussing this, speak to the doctors with regards to outcomes, speak to the doctors with regards to overall cost of care. Money talks. Hospitals don't want to spend a lot more money. Insurance providers don't want to spend more money. And if we can have better collaborative care, it decreases the cost for patients, it decreases the cost to hospitals and to insurance companies, and it ensures improved healing times, shorter healing times, then that people can get back to better quality of life, which at the end of the day, that is what we want. We want people's quality of life to be extremely good. We want it to be way better than what it was before. So I think that that's hugely important. Someone asked, what is the cost of training at AMREF? And I'm going to direct you to Banda Henry so that he can discuss that. The program is phenomenal. Wilfrida, I don't know if you have any idea as to the intricacies of the program in that way, but if you do, you can feel free to share those as well.
I would love if Henry is on the webinar. Can he kindly come on board and just talk about AMREF? If not, then I can help.
Let's see if our friend is here. All right, so Henry, you have been requested. So I hope you're here and I hope you can join us and give more information with regards to the program at AMREF. Can you hear us?
Yes. Hello.
Yes, we can hear you. How are you?
Thank you so much. Thank you. Fine. Thank you, Dr. John. Thank you, Dr. Dionne, and thank you, ma'am, for the presentation. Specifically to pelvic health physiotherapy program, we have second cohort intake going on. We are closing on Friday, and the program takes 2 years to complete with physical labs 1 week of every 3 to 4 months. The rest of the contents are delivered online. The entire school fee is 355,000 Kenya shillings. However, through the work collaboration between Amref Health Organization and the Jackson Foundation, there's a scholarship for the first 9 ladies to sign up for this course of up to 100,000 Kenya shillings, giving them remain with 255,000 for the tuition for the 2 years. So basically, that's the latest information that we got. Thank you.
Absolutely. So I hope that that's helpful, and I hope that you guys take advantage of this program because, again, you know, having only about 40 pelvic health physios in a country as large as Kenya it's not a lot, right? And we need all the help we can get to help not only women, not only pregnancy and postpartum and dealing with fistulas and FGM, but even for our male counterparts, erectile dysfunction, chronic pelvic pain, prostatitis, individuals who may be dealing with cancer, helping them with cancer rehabilitation, whether it's gynecological cancers or prostate cancers, male cancers, including testicular cancers, penile cancers, and so on. And also looking at our pediatric patients. Again, mom just mentioned, you know, a lot of the times that we're dealing with fistulas, these individuals may have underlying conditions that have gone on for years that have never been addressed and could have been helped with pelvic floor physiotherapy even in childhood years. And I see a lot of women as adults in my clinic whereby they're dealing with issues with regards to constipation. They're dealing with lumbopelvic hip issues that they've dealt with for years, and they just assumed it was normal, or they just assume that that was just their course in life, when realistically, these are things that if they'd been encountered earlier, could definitely have been prevented. So something to consider, as we discuss, and have more of these conversations. As far as recording, we will have a recording up within the next few days. And an email will be sent out to you. For those of you who attended the webinar last week with Henry, we will have that recording up today. But again, if you have any questions, let us know. We will also send out an email with regards to other topics that will be coming up. In March is here in the US, it's Endometriosis Awareness Month, and Dr. Dionne and I will send the date for a webinar that we will conduct discussing endometriosis, educating on what is available in terms of treatments, information, and so on and so forth, so that again we can start helping these populations. And in April, we'll have Mom back, Miss Wilfrida, to discuss female genital mutilation and its impact on pelvic health and pelvic floor rehabilitation. So stay tuned to that. We are discussing making sure that you guys can get some credit as far as clinical education goes, and we will be in touch with just further information with regards to that. So stay tuned. But we definitely want to make these conversations also worth your while. So not just getting the information, but making sure that it can count towards that for you as well. Mom, any last or final comments with regards to this topic?
Thank you very much, Daktari. I long for the day that I would reach the woman at the village, the one who is traveling for 800 kilometers to reach KNH or 500. That's my wish list. I long for the day we will be able in this country to be able to reach them so that they don't have to travel that far. That's one. Again, to the physios, please jump onto this boat and learn. It will be for yourself. If about pelvic floor, it's like all of us suffer one or another condition in ourselves that we don't even know until you come back to that class and then you realize, oh, so I was also a patient. So please come on board and enjoy this course when the experts are still available. And to the physicians, if there are any listening to us, especially the ones from Kenya, please let us work as a team for the quality of care to that particular woman or the patient. And for our colleagues, nurses, occupational therapists, clinical psychologists, we all want to make it better for the patient so that we give them quality of life out there. Thank you. That's what I can say. And if there was anyone else who was listening in who is not a health worker, I hope you've learned something that can help you or help someone you know. Thank you.
Absolutely. Thank you so much for your time, Mom, and this presentation. I know that this information is going to help so many people. I certainly enjoyed it, and I think it was wonderful. Dr. Dionne, any final words?
Thank you all for joining us. Mom, thank you so much for taking the time and effort to be a part of this with us and to help better educate us. I know we've said it before, I'm gonna say it again. This is something that we don't see a lot of in the US. So it is nice to see how proactive you all are being in Kenya and different things that we can take from that as well. So that way our physios here can continue to grow, continue to develop. And then I'm also going to do a quick plug for AMREF because even if you have no interest in pelvic health, you're seeing these patients. You probably have heard someone say, oh, I'm constipated. I have not, had a bowel movement in several days. That could be a pelvic floor issue. So it is at least advised that you have a basic understanding of this knowledge so that way you can best guide your patients, because you may be the only person that they've confided in with that information, but you also may be the only person that is best equipped to treat them without necessarily adding more medications or more treatments to their option that may be a bit more invasive. So take time to consider, what else can I learn? And even if hey, I don't want to be a pelvic floor therapist, I don't want to treat that, learning the basics can really help to progress what you're doing as a physio. And as someone who started off as an ortho physio, pelvic health has been what I've needed to kind of complete the circle, because there was a portion that I was missing and I did not understand until I started learning more about the pelvic region. Thank you.
There's a beautiful face. Hi, beautiful.
I didn't know my camera was off. I didn't know my camera was off until now.
That's okay. Well, you know what? Better late than never. We are excited to see your beautiful face.
Wow, I'm so excited. Thank you so much for giving me this opportunity.
Our pleasure. Thank you. Thank you so much. Thank you so much. All right, guys. Well, if you have any questions, like I said, we'll send out the emails. Feel free to respond to those. But we will be in touch with our dates for March for our webinar on endometriosis. And then again, we'll be in touch for April when we discuss female genital mutilation. So thank you all so much for your time. Thank you for being here. And we will see you again soon for our next webinar. Take care.
Thank you and goodbye.
Thank you.